Thank you.
Thanks, Mitra. Hi, everybody. Presenting this case might be a little bit of a moot point because I fear that this patient may have dropped out of the program as of Friday or today. But I think there are a couple of learning points for me, and so I decided to still proceed with my presentation. So this is a 35-year-old Caucasian female. She has Medicaid insurance. She started in our program in late January of this year. She, her drugs of choice were heroin and cocaine, which she uses intranasally. And since starting in the program, she was continuing to use cocaine every day, actually. And in her UDS, when she would come in weekly, there was also meth and ecstasy. She said she wasn't purchasing those, but they were in her Coke if she wasn't purchasing them. One of the big problems with this patient is her this cocaine use, and I'll get to that in a minute, but the other was that she just was really struggling to maintain our program requirements. And she would say that work prevented her from going to NA meetings or keeping her behavioral health appointments. In fact, she never even had her first behavioral health intake appointment. We just kept rescheduling, and she would miss it. Ultimately, she missed enough NA meetings that we placed her in IMAT, and then she just often wouldn't come to those daily IMAT appointments. And all through this, she would come to her Wednesday medical group visit meeting and be very apologetic and say she, really, wanted to get sober. And she was also extremely frustrated with herself about the continued cocaine use. She, at a couple of points, said that she thought she was addicted to snorting. And I thought that was one of the interesting things just to talk about today. I remember a couple of years ago, I presented, or I don't know when it was, but anyway, about one of our clients who felt he was addicted to the needle. She was pretty frustrated. Anyway, a month ago, I started her on Wellbutrin. And the last time I spoke to her, which was last Wednesday, she said she thought that was helping her depression, but she didn't think that it was helping her stop the cocaine. She said at this point, she wasn't even sure why she was using the cocaine other than to be able to snort. And she said she no longer gets high from it. And as I said, she was very frustrated with herself. She was released from prison about a year ago after serving a 5-year sentence. She really didn't want to go back to prison. Her family doesn't know that, she thinks her family doesn't know that she is using again. She works at a local convenience store where she says she gets really odd hours. She doesn't have transportation. The convenience store, we know that there's a lot of drug dealing that goes on there. So I'm sure that was not a great environment for her. Her past medical history, she started using marijuana and alcohol at age 11 and then started using pills at age 15. She had been in a Suboxone program prior to going to prison. And she was actually purchasing Suboxone on the street when she came to our program. And when she would miss her IMAT programs, she would have, gotten hold of Suboxone. So she continued to use the Suboxone and stayed off heroin as far as we could tell. At any rate, it seems like the 5 days of in-person IMAT visits were too much for her. And it seems that she may have dropped out. Amy Lively is on here, but I don't think we've heard from her since last Thursday. And so I was curious from the group about I guess there are three things that I really struggled with this woman. One was, not meeting program requirements. Two was her daily cocaine use. Any thoughts on that? And three was, and most interesting to me, is this question of people who say they may be addicted to snorting. So those are my questions, and I think that's it.
Thank you so much, Jen. That was a wonderful case presentation. Great questions that come along with that. Before we jump into the recommendations and feedback, did anyone have clarifying questions? And feel free to unmute or chat in. All right, and does anyone have any recommendations or maybe some feedback to some of those questions that Jen had? And I'm happy to pull up the case as well.
Well, there's a couple things that I have thoughts about. So one issue is social group reconstruction. So, where is the drug dealer? Is there a number in her phone? Is it somebody at the convenience store? Does she need to get a different job or change her environment so that it's a healthier environment? And then another idea is that antabuse can be helpful for cocaine cravings.
Oh.
So that's another option pharmacologically.
Thank you.
Hold on, let me turn this off. I'm sorry, I'm echoing. All right, turn it off. I'm sorry. Sorry, there's two of us in this office, so I echo just a little bit. I have a couple questions, a couple thoughts. So first, we'll start with my thoughts and ideas on the behavioral aspect when it comes to the rituals of cocaine use. Just like anyone who uses a substance, whether that be smoking cigarettes or rubbing snuff or shooting heroin, I do think there's a behavioral component, a ritual component that can be part of the addiction, such as you think about people who say, oh, I can only use $100 bill to snort my Coke, or I only like McDonald's straws, or different things like that. So there is that aspect to the addiction part. And so she might not be experiencing the high so much anymore, depending on what her cocaine is being cut with. And I don't know what that looks like in your area, but here in our area, crack cocaine seems to be our biggest issue. So yeah, I think her coming forward and talking about the addiction of the process of snorting Coke, depending on what that looks like to her, that is a realistic issue she's struggling with. Here in RMAC clinic, I know that people who are often behind in their behavioral health appointments, or they skip out on their behavioral health intake with us, we will grab them. We will have somebody grab them as soon as they walk in our clinic, and we will see them first before they're seen for medication and try to get that knocked out.
Interesting.
Yeah. So, and that's, I think, typical too of drug addiction. And we're not always responsible. Sometimes we don't know sometimes how to be responsible. And it sounds like she's working in a not so healthy environment. And if she's working all these different crazy hours, it may be difficult for her to be there every day. I recently had a patient who was working in a vape shop. And I said, that's kind of like bartending sober, trying to practice recovery and having struggles with alcohol, and saying, oh, bartending's the job for me. And that patient has since quit that job and is going back to try to find something more healthy that will allow her to focus on her recovery. And then my last thought on the whole situation is are you guys using any type of reward program, such as contingency management or a voucher program for stimulant use? And I will stop talking at this point and let other people have room.
Yeah, those were really helpful comments. And we are not, we don't have our own contingency management program, although we're hoping to get one in place. But we are participating in a study with the Dynamic Care app, and we had offered her that, but she declined. So we've had people who are involved in that study talk about it in group. But we hope to have our own contingency management program in place, you know, at some point. So that was interesting, your comments, thank you. And I'm assuming that it's just behavioral therapy is the treatment for the whatever the ritual, you know, for whatever the rituals are that keep people hooked in that way. Am I right on that?
Yeah, I think with the use of CBT or some DBT would be really good. I'm an ex-smoker, and I know that I had rituals with smoking cigarettes. There were certain times I smoked, and so if you think about and eating can also be the same. We celebrate a lot through food, and
Yeah.
so yeah.
Thank you.
Thank you so much, Tanya. Those are great questions and comments. Were there any other recommendations, feedback from the group for Jen's case? And Jen, were there any other questions you wanted to maybe have addressed about your case, or maybe you wanted to discuss with the group?
Nope, that was it. That was all very helpful. Thank you all.
Awesome. Thank you so much, Jen, for the case. Dr. Bo, I noticed you unmuted. Did you have a comment?
Yeah, just pharmacologically, I've had some success with Topamax for cocaine at 50 milligrams twice a day, up to 75 milligrams twice a day. I think the recommendation is over 100. It's not that helpful.
I'm sorry, can you say that again, Dr. Bo? I was fooling with the speaker on the phone and I missed what medication you said.
Topamax, for some people, is very helpful for cravings for cocaine.
Okay, great. Thank you. I had learned that at the I actually just started one of my meth patients on that, and I'm glad that you brought that up, because I could consider that for this person too, and then the antabuse. So thank you.
One other thing is, you know, when a patient is failing a given level of care, you always want to think about intensifying the treatment. And so maybe rehab would be a nice setting for this patient to be away from substances for a while and, you know, just to live a sober life in rehab for a while to get ready to return to the community.
Yeah, that's a good suggestion. We had discussed that with her, and she discounted that out of hand. We mentioned it 2 weeks in a row, and then last week I also just suggested maybe for her to try a detox. You know, even a very short-term detox setting just to reset. But she just was not interested in. The rest of the team thinks that she's just not committed and just not ready. But I was moved by her presentation when she would come and the things she would say, and so I just persisted. So anyway, I'll keep that in mind if she, you know, if she returns to the program, just to encourage that, because I think that's probably right. She needs a reset on her life too, and rehab would help with that.
Thank you, Dr. Bo and Dr. Hirschler, for those comments as well. Any other comments from the group before we move to the didactic portion? All righty, well, thank you so much, Jen, again for that case. We haven't had a case in the SUD echoes in a while, so it was really great to have that discussion. We appreciate it a lot. Dr. Hirschler, I'll turn things over to you now. I have your PowerPoint on my end as backup if tech kind of glitches for any reason, so just let me know, but I'll turn things over to you now. Thank you.
me try sharing my screen. All right. So I was asked to speak about addiction case severity. And as an addiction specialist, you want to be somebody who patients refer their sickest patients to. And so this is kind of the bread and butter of being an addiction specialist, is to be able to handle the toughest cases. And so we're going to talk about some models to deal with these kind of difficult patients. So you might even think about this as like a pile of snakes, that need a way to handle all the things going on in the person's life. So I have no financial disclosures. Here's the objectives of what I'm going to talk about. So I'm going to define case severity. I'm going to describe how case severity impacts outcome. I'm going to describe the module strategy to address case severity and describe how levels of care address case severity. And then we're going to go over some sample cases. There'll be some discussion points, and then I'll maybe have some future directions to think about. And please, if you have any questions while I'm talking, feel free to chime in. I think it's useful to get a good discussion going about these ideas. So Ralph Waldo Emerson once said, "Bad times have a scientific value. These are occasions a good learner would not miss." And so, my attitude is to kind of welcome these toughest cases because, the severely ill patients, because it gives you an opportunity to learn how to manage them well and handle the most difficult situations. And when you're learning from a mentor, you want to know, how did they handle their toughest cases? And then along the same lines, the African proverb, "Smooth seas don't make skilled sailors." So you want to have some rough seas to develop your sailing talent. So back when I worked at the VA hospital in 1997, we used something called the Addiction Severity Index. So this goes back a long time in the field of addictions. And basically, it's a general overview of the substance use problem. And they divide these problems into 7 functional areas that are shown to be effective by substance use. And so you've got the medical condition of the individual, their employment status, drug use and alcohol use, their legal status, and their family and social status, and their psychiatric status. And so they actually had a computerized program to do the addiction severity index scale on all the patients that were part of the methadone program or the substance use disorders program. And so Tom McClellan in 1998 did research on the ASI. And what he found is that patients who re-enter treatment programs often present with more severe addiction problems, according to the ASI. And what he found is that they have difficulties that weren't addressed in their previous treatment episode. So things are being missed in the treatment of the patient that lead to relapse of addiction. And so a more severe ASI profile was found among those patients who came back to treatment compared to those who came for the first time. And so what we're learning basically from this is that the patients who relapsed and did the poorest had the greatest needs. Now, Dave McDuff, who's a sports psychiatrist in Baltimore, he's the lead psychiatrist for the Orioles and the Colts also. He used to be the Ravens lead psychiatrist, but now he's the Colts lead psychiatrist. And he's an addiction specialist. He developed this model of complex addiction. And I've kind of expanded on his model, but I think it helps to think about what makes a case complex. And so we've got several items here. So multiple substances makes a case complex, and particularly when you have upper-downer pairing. So if someone's using uppers, they may be self-medicating. If you think about the Kantian theory that people self-medicate with substances, so if somebody's depressed, they may use uppers to feel better, or if someone's angry or they're anxious, they may use a downer to feel better. So why do people use up or downer pairings? And so that's kind of a more complex case. And then risky routes of administration, like smoking and injecting. So it's the speed of onset of action of a substance that makes it most reinforcing. And so if you think about injecting or smoking, the speed that it gets to the brain and the in between the actual using and experiencing the intoxicating effects is very rapid. And so that makes it highly reinforcing. It makes it a more complex case. And then developing serious medical or psychiatric comorbidity or cognitive impairment makes a case complex. And underemployment or low education can make things more difficult. Concurrent dealing or criminality, people having trauma issues in the past or current trauma issues happening, and also grief and loss can make cases more complex. Addiction during pregnancy can make it more complex, and multiple concurrent addiction types. So sex addiction, substances, food, gambling, shopping, even internet addiction or video gaming addiction. And then complex social factors. So gang affiliation, being associated with a marginalized group, cultures associated with high addiction stigma, and family dysfunction and divorce. All these social aspects can make cases more complex. And then languishing. So when a patient gets stuck in kind of a dysfunctional state, so relationships being stuck or work and school or poverty or homelessness. So that kind of stuck state, that languishing state makes a case more complex. And then early and late life addiction cases can be more complex. When I worked at, blanking on the Annapolis rehab that I worked at, I'm Pathways, it was called. There were people that were 13 or 14 years old that were involved in prostitution and all kinds of terrible behaviors related to addictions at that young of an age. And so that can make a case very complex for a young child. And then late life addiction cases often have more severe medical problems and other cognitive issues that can be a factor in addiction cases. And then lastly, prominent individuals with a significantly developed career can make cases complex. And so often they struggle with a lot of shame, and their impairment affects a whole group of people because of the importance of what they're doing with their lives and their career. And so those prominent individuals with addiction can be very complex cases as well. So here's some information from the National Survey on Drug Use and Health that points to complexity. And there's not a lot of literature about kind of the data of how common complexity is, but I think you'll find in your clinical work that it's very common. And often it's not just one element that makes things complex, but multiple domains are being affected. And so in 2014, 43.6 million Americans had some form of mental illness, and 20.2 million had a substance use disorder in the last year. And of those 20.2 million, 11.3% had both an alcohol use disorder and an illicit drug use disorder. And 7.9 million had both a substance use disorder and a mental disorder. So all these comorbidities are super common. And then in 2012, 6% of pregnant women were using illicit drugs and 8.5% drank alcohol. So you've got a lot of substance use in pregnant women too. And so you can see that some of these issues of complexity have some data supporting how common they are. And another way of looking at this is to look at what I call a general life review. And so you can divide life into 10 domains. And if you look at an addicted person's life in these 10 domains, you can kind of see where the consequences of substance use are and just all the problems that they face. And so we're talking about physical health and mental health and recreation and leisure and marriage and family and social life and environment and housing and transportation and education, work, finances, and legal issues and their appearance. And even their spiritual life can be ill-affected by substance use. And so this is another model to kind of look at how severe this person's addiction is, what's it impacting in their life. So let's talk about how you tackle case severity using these models. And so the first thing I'm going to suggest is that work streams be modularized. And so what I mean by that is that you're going to have some recognition of the patterns in the person's life, and then apply the best evidence to the evidence-based principles to the whole clinical situation, and divide each problem into modules where you can have the team break down these complex problems into the modules, and then have have a strategy to deal with each individual module in the person's life. And also, when you divide their kind of complex problems into modules, that reveals gaps in the addiction program. Maybe you're not meeting employment needs or legal issues, or maybe there's some aspect of the patient's life that you kind of sweep under the rug that really kind of irritates their recovery and makes it difficult for them to improve their life. And so what you want to do is align the patient's needs and pain points with the right people. So that's the module approach. And so when you have the module approach, Rusk and that group in 2018 said, if you just change a single module, that may fail to tip the system into a new stable state, and relapse can occur. And so changes within multiple modules can have a synergistic reinforcement effect, and that helps to tip the system into a stable pattern. And so if you have unchanged parts of the system, that can undermine the attempt to change, leading to relapse. And sometimes changes in one module can spill over into the others, and you kind of get an interaction between domains that helps to tip the system into stability. And especially when you have potent changes in the system that are a good fit for the individual, that's when it promotes useful changes in an upward spiral. So here's a diagram of what I'm talking about. And so if in A, you have all the 5 areas of functioning that can be improved, and you change one module or one domain. And so that tips that you see that ball moving in B. But in C, you get relapse because it hasn't stabilized. But in D, you have multiple domain interventions. And so you tip the scale. And in F, you have stabilization because you've tipped the system with enough modules changing. So that's the module approach. And then also you can tackle severity of illness with the ASAM levels of care. So we're talking about that with the case just a minute ago. So you want to select the appropriate level of care for the individual situation. And ASAM guides us about how to select the right level of care. But you've got these different levels of care: early intervention, low intensity outpatient, intensive outpatient and partial hospitalization, inpatient rehab, medically managed inpatient. And so, somebody's an alcoholic and they've had DTs or seizures, they're going to be required to be in a medically managed inpatient unit where it's safe for them to be detoxed off the alcohol without having a serious medical outcome. And if for example, with this case that we talked about, so maybe inpatient rehab is appropriate for somebody who just can't seem to get any kind of sobriety time in an outpatient setting. And so you want to think about what's the appropriate level of care for the person. And the basic premise to this is, if the patient is failing the current level of care, intensify the treatment. So you don't want to kick them out of treatment if they're failing a level of care. You want to offer them more treatment. And that does a couple things. So first of all, the patient has to make more time commitment to the treatment because it's a higher level of care. And so that's an incentive alone for them to want to be sober so they don't have to commit so much time to treatment. But also you're giving them more treatment. And so the additional treatment is also going to work in their favor to get this severe addiction under control. I hope that makes sense to everybody. All right, so I'm going to go over some case examples. And these cases are not actual cases. I've been practicing for about 27 years, so I've seen a lot of kind of different scenarios. And so these are kind of drummed up cases that represent the sort of things that I've seen over the course of my career. So here's an example. 29-year-old male with a history of severe opiate use disorder, cocaine use disorder, and alcohol use disorder, an unspecified depressive disorder, has been treated for 2 years with Suboxone, Antabuse, and Celexa. He's very intelligent and enjoys reading the Harvard Business Review. He has supported himself for years by dealing drugs in the local community and has faced some incarcerations for possession and distribution. He had a long-term relationship with a beautiful young lady who left him because of his persistent languishing state of little to no growth, of not going anywhere. And he remained fixated on this woman. He never worked other than some infrequent solo music gigs. Eventually, after years of treatment in which he was stable psychiatrically, he relapsed cocaine and alcohol use. He failed intensive outpatient level of care, anti-abuse and Camprol. He was sent to inpatient rehab, and following his discharge, relapsed again and then refused to go back to the rehab and was eventually administratively detoxed off Suboxone. His addictions therapist saw him as entitled and resistant to change, and he revealed that his guilt, and that maybe he was sabotaging himself as a way of punishing himself for his past misdeeds. And in particular, he was feeling guilty for introducing his best friend to drugs, who was living a terrible life in and out of jail. So what do you guys think? Why is this case severe or complex? And what are the aspects of it that make it complex or severe? Any ideas?
Dr. Hirschler, I'll monitor the chat for you if anything comes in.
Okay.
He has multiple substance abuse.
Yeah, and also upper downer pairing. So he's using cocaine and alcohol and opiates. So you've got downers and uppers there, right? So this is the substance choice is a severe issue, right? What else?
Languishing.
Yeah, so he's stuck. He was fixated on this lady, but she was unhappy with him because he's dealing drugs and not going anywhere with his life. And she had hopes for somebody who was maybe more mainstream successful in their life. So he's kind of stuck in this persistent dysfunctional state. What else?
He's got a crappy job dealing drugs.
Yeah, so criminal behavior and dealing drugs. So that's
Like-
another issue that makes it complex.
Yeah, relationship issues,
Mm-hmm.
complex.
And he's already failed outpatient.
Yeah, so he failed all the levels of outpatient, and he failed inpatient, and then didn't want to go back to inpatient. So yeah, this guy's really stuck. So multiple substances, upper downer pairing, dealing, languishing, criminal history. Oh, and psychiatric comorbidity, right? So he had an unspecified depressive disorder. So how do we handle this guy? So what about the modules approach? What are his modules?
The matrix.
Well, I couldn't hear what you said, Jamal. Say it again.
The matrix module, they have to be involved more than issue, the medication, the motivational interview, the individual counseling.
Right. So that's how you address the addiction issue. So of course he needs therapy and he needs medication, which those things have been attempted. But so maybe some of these other needs that he has, if you think about McClellan's research on the ASI, so maybe some of these other needs that he has need to be addressed. So one thing is he's lonely, maybe. He was fixated on this woman and he has no partner. And so maybe something needs to be done to address it, find new places to connect, and maybe abstinence would be support. If he could develop a life of abstinence, maybe that would improve his chances of developing a meaningful relationship with somebody, right? And then these legal issues. So he has a criminal history that can make it hard to get a job, right? So in Morgantown, we have something called Appalachian Reintegrate, which is a program that helps people with legal issues and substance use disorders get a job and start working and getting back to work. So, maybe he needs some supported employment to get his work situation improved. Do you see how meeting these module needs might help assist him in his recovery?
Yeah, but inside our programs, how do we actually go about, because many of our patients face similar issues, And in terms of case management, yeah, we can help some of the social in terms of getting IDs, referring to DHHR. But a lot of times when it comes to the legal, I'm not sure what to do. I mean, we can write supportive letters to get some things expunged from their history, but pretty much in Charleston, there's just 1 or 2 places that would take people who suffer from substance use disorders with a criminal background. And I don't know of our other resources.
So that's going to require some advocacy on the behalf of the addictions field, to say, look, if we're going to help these people improve their lives, we have to open some doors for them.
Yeah, interesting. So I found out one of our client patients told me if they apply through an employment agency, it's easier to get employed, even if it's at the same job. So just something to consider for them doing through employment agencies. I don't know why that is, but they may end up in the same job, but we've had some people be able to get employed even despite that, having some felonies.
All right, so that's good. So let's look at the next case. So this case is a 38-year-old male with no prior psychiatric history who presented with depression and suicide thoughts with plans for suicide in the context of cocaine use, which he smokes. And he feels unsafe and predicts that he will end his life if he doesn't get help. He is a bit childlike in character. His father left the family when he was young. He has an estranged relationship with his stepbrother due to incest. He has never had a depressive episode in the absence of drug use. During his hospitalization, he also reported sex acts with dogs, which is distressing to him. He refused to further discuss this behavior during his hospitalization. His use of cocaine is out of control. It has caused consequences in several domains of life. He's experienced tolerance to the drug and withdrawal symptoms. So what do you guys think about this case? What makes it severe or complex?
Substance induced.
Yeah, well, right. So he's got a psychiatric issue here that makes the case more complex. And it does seem to be substance related because it doesn't happen in the absence of substance use. And it's very severe. So he's suicidal and needed to be hospitalized. So the level of care is inpatient psychiatric unit because he's suicidal, right? So you have to meet the needs of the patient with levels of care, right?
And you got to wonder whether he's got some PTSD, under all this, or trauma history, it sounds like, on top of that.
Mm-hmm. I guess we don't know from the story, but it sounds like that kind of a scenario, right? Another psychiatric issue kind of borders on addiction for him. Sex acts with dogs is considered a paraphilia, but in some ways it's like an addiction behavior, a sex addiction. And perhaps this guy is using cocaine and then having sexual relations with animals, as part of a cocaine high. And so it's all an addictive behavior process. So that can be a complex addiction in that way, that you've got multiple kind of addiction types going on. Anything else you can think of that makes it complex? He's smoking the cocaine, right? So it's a rapid onset of action. So you gotta, that effect also. Let's see what my notes say here. All right, so multiple addiction types, risky routes of administration, languishing, psychiatric comorbidity, complex social factors, and loss. Yeah, he's estranged from his father. His father left when he was young. So what do you think about the module's approach to this guy? Well, I'll offer some ideas. So part of this is this sexual history is troubling him. And so maybe a more appropriate setting would be for him to develop relationships with people instead of animals. And so you could facilitate that maybe with gay AA or NA meetings, which they have that sort of thing in Baltimore. So maybe that would be something that he could be involved in. And psychotherapy, of course, and medication. There's pharmacologic treatments of paraphilias. So addressing the psychiatric issues, outside of the depression, which is going to resolve when he's off the cocaine. Other thoughts? Do you think a guy like this belongs in the hospital who's on a cocaine crash and suicidal? I
Yeah.
see Michael shaking his head.
Yeah, he would benefit from inpatient stabilization. And then even from there, he could be connected to probably inpatient rehab afterwards. And he might even be a good person to consider sober living for.
Yeah, so it's an interesting case. All right, here's another case. 35-year-old female with a history of PTSD, opiate and alcohol use disorders, who was injured in a motor vehicle collision and had several serious fractures requiring surgery. She was started on Suboxone for pain, and her opiate use disorder titrated to 12 milligrams, 3 milligrams, total dose per day divided into 4 milligrams, 1 milligram, TID with a partial analgesic response. She is in physical therapy to improve her range of motion. She has intrusive memories of the accident, but no longer has nightmares of it. She denies being under the influence at the time of the accident, and there was no DUI charge. She's taking Zoloft 50 milligrams a day for PTSD. She's able to drive. She doesn't startle as much as she did following the accident, and she now has a softer vigilance. She has degrees in marketing and communication, but works as a waitress. She resumed work at a restaurant, but her environment is filled with substance users, including coworkers and at the bar in the restaurant. She socializes with coworkers and drinks alcohol heavily at times. She was started on Campral and Antabuse after a period of abstinence from alcohol while in the hospital, but she became non-compliant with both of them after her discharge. She lives alone and there is no one available to a supervisor taking the Antabuse to guarantee compliance with it. She has been abstinent from opiates with a current treatment with Suboxone. She was raised in a religious family and they have banished her from the family because of her substance use and in their view, more immoral lifestyle. The family problems and underemployment are her only perceived consequences of substance use. So what do you guys think about this case? What makes it severe and complex?
She has comorbid PTSD. She has an unstable work environment. She's lost her religious support in terms of her family. She's under-medicated for PTSD. And she also probably has chronic pain.
Yeah, so she has pain. She has undertreated pain and undertreated PTSD. And her environment is a terrible recovery environment. She's underemployed. She's working in a restaurant, but she has a marketing and communications degree. So she's kind of underemployed. I think we got most of it. Yeah, the social situation is terrible with her family, being the stigma kind of is alienating her from her family. That's a tough thing for a patient. What were you going to say, Jamal?
What's that? What's that, John?
I thought you were going to say something.
No, I agree, whatever. I'm just.
I think Tanya, did you have a comment? I saw you up there.
Yeah, I was just going to comment on the fact that she's socially isolated, even though she's out drinking alcohol with coworkers. She's isolated from people who care about her, and she doesn't have that sense of self-worth.
Mm-hmm. All right, so that's a perfect foray into the modules approach. So what are her modules and how can we address her needs in a treatment plan?
Better treatment for PTSD, better treatment for her chronic pain.
Yeah, all right, so the medical issues, yep, the pain and the PTSD.
Maybe get in some EMDR as well for the psychotherapy and connect her with a support community.
Mm-hmm. So she needs social group reconstruction badly, right? She's her employment is a terrible environment. So we need to get her in an environment where it's going to be supportive for her. And maybe for somebody with her background, that's a religious environment, that maybe a spiritual practice or something would be good for her to get back into.
That's what I was going to say. I could see Celebrate Recovery being a huge support from her because while she's been as you said, stigmatized, shamed by her religious family, to get that religious support from that community is probably really helpful.
All right, so let me see what I have here. So why is this case complex? Multiple substances, so she's using alcohol and opiates, medical comorbidity, psychiatric comorbidity, underemployed and complex social situation. So what about her level of care? Does she require rehab or inpatient, medically managed inpatient, or can this be managed as an outpatient, or what do you guys think?
How much was she drinking? You maybe said that and I missed it.
She's a binge drinker, so she drinks heavily with friends, but it's not like every day.
She can have intensive outpatient.
Yes, that'd be a good level of care for her, right? All right, so discussion points. So the ability to read the complexity and severity of difficult problems is an invaluable component of excellent care. And so basically what you're doing is clarifying the needs of the patient. So we get so focused medically in a medical model about the diagnosis and the appropriate treatment for a diagnosis. That's just not adequate for a severely ill patient. You know, I think you have to think about what is the needs that this person is facing and how can we address these needs? And perhaps the best way to do that is to modularize the work streams. And then of course, choose the appropriate level of care. And if the patient is failing the current level of care, intensify the treatment. So what about future directions? So what I would argue is that if we can modularize the work streams and create levels of care within each module, that would be the best way to address the needs. And so, you know, maybe we could have levels of care for work or levels of care for relationships, not just levels of care for health. Or all those, if you think about that general life review, all the legal issues, you know, what's the appropriate level of care for that person's needs? Or, you know, say, kind of thinking about the whole clinical situation. And so what you really want to develop is a complete solution. You know, how do we get a complete solution for this patient's presentation? So here's my references. Any thoughts about this kind of approach to severe cases?
Dr. Schler, I really like that approach. I know for me, I can get overwhelmed when they're so complex and it's hard to not, you know, you're just thinking of multiple ones at one time. And I really like the way this sort of separates things out for me in my brain, if that makes sense.
And if you work with a team, you know, you can have different talents within the team to focus on the different modules and address them by people who are specialized in the different area that someone's struggling with. And so we even reach outside of WVU, like Appalachian Reintegrate is not part of WVU as far as I know. It's a separate, a separate organization that's addressing employment needs of patients. Or Sober Living, for example, is not part of WVU, but it addresses the housing issues that come up and good recovery environments that come up for patients. And so you want to develop a system that can meet the needs of these patients so that they stabilize, you know, that all those modules get addressed and they stabilize in a new kind of recovering state.
Are there structural barriers to the team approach in terms of referrals and, you know, getting the patient everything he or she needs?
That's a good question. So for example, here at WVU, we do have an issue with therapy, you know, that sometimes patients have to wait a while to get a therapist. And so it's not, you know, treatment on demand, unfortunately, for some issues. And so that's a barrier. But it's an interesting thing to think about. And obviously those barriers need to be addressed.
Thank you for talking about this topic. One thing I really liked about it is how it put it can help our patients focus on things other than just not using, right? Because if we talk about, hey, you know what, we can get you in touch with someone who can help with the legal, or let's get you getting your ID, or let's get employment underway, they can start to see their recovery as a whole and not just siloed into medications.
Yeah, so the medical model is kind of incomplete for what the patient is facing.
Dina, did your kiddo have any maybe thoughts or feedback on that, on the module way of looking at things?
Yeah, he said he loved what Jeremy was saying, and mommy is pay attention.
That's right.
Thank you, Dr. Hirschler.
No, you're welcome.
This has been so wonderful, and we're getting a lot of great chats in too. Thanking you for the presentation. And Dr. Long mentioned, it sounds great. We have limited resources available. Absolutely.
So it's a way to grow, right? This seems to be an area of growth that would be important to meet the needs of the patients.
With any final comments, questions, or thoughts? About 5 minutes left. So Dr. Long says, I agree. How do you suggest we do that?
So maybe it means contacting the powerful voices in your department, who are the people who can influence the community and kind of say, hey, this is what science tells us, going all the way back to, that was 2000, I think, when McClellan, I forget what year that, or 1997, I can't remember what year that was, that 98, I think is his research was. So it goes back pretty far, kind of in the foundation of addictions work. So it's well-established stuff that we should be doing.
A couple of folks also mentioned Jobs Info being a great resource, especially in the beginning. Thank you, Tanya and Sarah, for adding that. Tanya mentioned for housing, I would look to your COC programs. There are 4 that covers the whole state. We also utilize legal aid. Thank you for adding that. Feel free to unmute if you want to elaborate or anything.
This is Jennifer Boyd. It occurs to me that it's one reason I'm pretty excited that our team is connected to the treatment court system in our county, because it offers an added support for those people who are involved in the legal system. It just sort of augments what we can be doing, and that team, I've never heard them use the word modules, but that treatment team in the courts is clearly looking, at least here in Fayette County, they're looking at the whole person, which is inspiring to see, and addressing different facets of that person's life.
Yeah, I think it's exciting to think about what the potential to transform somebody's life really is with a complete solution. I like the idea of a complete solution. So maybe not just a partial solution, but a complete solution for the individual.
These are all great comments and thoughts. Thank you all so much. Well, if there are no further questions or discussion or anything, thank you so much, Dr. Hirschler. That was a really wonderful presentation. As usual, I'll be attaching the slides to the recap email, so you all will have a copy of those. And thank you, Jen, as well, for your case. It was really wonderful and drove a lot of great discussion, so we appreciate that. The only announcement I have is that our next session will be on March 28th, and Dr. Aljari will be presenting on dextroamphetamine. Is it the buprenorphine for stimulant use disorder? I apologize if I'm not pronouncing any of that correctly, but I'll type it all out in the recap email as well. So thank you all so much. We'll see you next time.
Thank you.
Take care.